Good afternoon. My name is Paul Wax. I'm the Executive Director of the American College of Medical Toxicology. I'd like to welcome you to our weekly webinar series entitled The Medical and Public Health Considerations of COVID-19. Today, we're going to have two presentations. The lead presentation will be on the state of COVID-19 and contact tracing efforts. And this will be followed by an update from Georgia and the Georgia Poison Control Center regarding their local efforts in Georgia. Next slide, please. I'd like to thank our webinar series partners for helping to spread the word about this webinar series. Next slide. This webinar will be recorded and will be posted to the ACMT webinar page, which is at www.acmtnet/COVID-19 web. And this webinar will be posted in approximately 48 hours, and participants today will get an email notification once it's posted. There's also a webinar Q&A available at the same web address, and we will also certainly entertain any questions about the webinar series. You can contact us at webinars@acmt.net. Next slide. There will be a Q&A at the end of the webinar. This is the first webinar we're actually using a different platform. We're using Zoom. For many of you who have attended previous webinars, we use the WebEx platform, but the Q&A will be similar. Please chat in your questions either into the chat function or into the Q&A, and following the second presentations, we'll have a Q&A session, usually up until the top of the hour or sometimes a few minutes afterward. Next slide. There are no conflicts of interest for either of the speakers. Next slide. I'd like to thank my co-moderator, Dr. Ziad Kazi. Dr. Kazi is a board member of the American College of Medical Toxicology, is president of the Middle Eastern and North African Clinical Toxicology Association, and a clinical associate professor of emergency medicine at Emory University. Next slide. This is our 24th Wednesday webinar. We started this webinar series back in March, and I've had an assortment of very thought-provoking webinars on a weekly basis ever since. This is a headline from CNN just from a few hours ago. The CDC director, Dr. Robert Redford, testified to Congress this morning and said strikingly that more than 90% of the population remains susceptible to COVID-19. So this is quite a striking statement, and I think very apropos for the importance of the presentation today. Next slide. So it's my delight to introduce our first speaker. Dr. Watson is a senior scholar at the Johns Hopkins Center for Health Security and an assistant professor at Johns Hopkins Bloomberg School of Public Health, Department of Environmental Health and Engineering. She will be summarizing the current state of COVID-19 in the US, provide an overview of contact tracing, and discuss the future needs for contact tracing as the pandemic unfolds. Dr. Watson, thank you.
Sorry about that. My mute button was not showing up. Hi, thank you very much for the introduction. I will start the slides over here. I am very excited to join you today. Thank you very much for inviting me, and I'm anxious to hear your questions and have a conversation about the issue of contact tracing. First, I will give just a general update on the state of the pandemic, although I'm sure many of you are following along very closely, but to get us all on the same page, I thought that would be helpful. So I wanted to start out by briefly addressing what is still uncertain, what is our uncertainty in the science about this virus and the pandemic and how it's unfolding. So there are a few areas of still high uncertainty. The first is transmission locations. While we do have a better understanding of where transmission is happening, where it's a higher risk, we still don't have a great understanding of what is driving epidemics or outbreaks of this virus. We know that there is more transmission in congregate settings, for example, but what is still unclear is whether that in and of itself is driving much of the case numbers that we're seeing, or is it more community transmission? We need more data to better understand this, and some of that is going to come through contact tracing, which we can talk more about later. There's also still a lot of debate and uncertainty about transmission itself, the modes of transmission, as well as the activities where transmission occurs. So we do know that there are higher risk activities like singing, talking loudly in settings where people are close together. Some medical procedures that are aerosol generating can produce more aerosols and are higher risk for transmission. We also know that some people are actually super emitters of this virus. They produce a larger percentage of aerosols than others and can cause super spreading events. And we do know that fomites are responsible, we think, for some level of transmission, but we don't really know what percent contribution fomites have and surfaces have to the overall transmission, because it's very difficult to tease out fomite transmission from other close contact. And so one of the big debates raging right now, and CDC has just gone back and forth with some of their statements and guidance on this, is what percentage of the transmission is aerosol versus droplets. We think from the epidemiology that that droplet transmission is still driving most of the transmission of this virus, but obviously we have these super spreading events where aerosols are implicated, and so we still need to understand better about kind of the cause of these super emitters, what biologically is driving that, and what percentage of the transmission is actually occurring because of aerosols versus droplets. So there's still a lot of uncertainty here. We need more science to inform how we can understand this and to inform the public health measures that we're using to respond. There's also a good deal of uncertainty still around immunity. The data coming out on this are showing that there does seem to be some protective immunity for most people who are infected, even if it is a mild infection. But we still don't have enough data to fully understand how long that immunity lasts. There is some emerging information that at least in some people, immunity starts to wane after 3 to 4 months, but we don't know how uniform that is. And so we also just need more time and more information to make better judgments about immunity. So looking at the national trends for COVID-19, this is the epi curve from the New York Times. This is a couple of days old, so unfortunately we have now passed the milestone, I think today, of 200,000 deaths in the US. And we are at about 7 million cases reported of COVID-19 in this country. As you can see, we had the early spring wave with the first emergence of this pandemic. We implemented social distancing measures, stay-at-home orders, and business shutdowns, and we brought down transmission, flattened the curve, not all the way down, but to some extent. And then we had that second spike in the summer once we began to release those measures and people came together more and relaxed their personal protective actions. Once again, we were able to stem that surge, but now, unfortunately, we are seeing some additional rise in case numbers, and there's still some uncertainty about what this will look like in the fall and winter, but I know there are concerns that we will see additional waves or spikes in cases nationally and also regionally. And I think if you look at the data coming from Europe, that also confirms that there may be additional waves of this virus to come. So to look a little bit more in depth at the current status, as you can remember from back in the spring, most of the transmission, most of the cases were coming from the Northeast and some of the Western states. And then the focus of the second wave of transmission really was kind of the Sun Belt, the southern states. And now what we're seeing is a lot more hotspots from the middle part of the country, the Midwest. And so it's not as focused as those earlier surges in cases, but we do see that there are parts of the country that are experiencing some really high incidence of disease right now. And so we have to keep an eye on that. And as Paul just said, there are a vast majority of individuals in this country who are still naive to this virus. And so unfortunately, there's a lot of susceptibility, and so we need to be on our guard for the fall and winter. So this is another good indicator of what's happening in transmission and our public health response. This is from the Johns Hopkins COVID Research Center. This is looking at the test positivity nationally. As you can see, back earlier in the year, we had very little testing. And so we have seen a really impressive increase in testing capacity nationally. Over the summer, when we had a rise in cases, that capacity was depleted to some extent. We had long delays in return of testing results, and just some systems that were overwhelmed. So you see a bit of a dip in the testing capacity there. But now we're also seeing some additional types of testing become more available. So specifically antigen testing, in addition to the PCR lab-based test. And so we're seeing that there is additional rise in testing availability. And so if you look at the line in the middle of this graph here, that is the average percent positivity rate. And you can see we're down to about 5% nationally, which is the WHO's recommended level for test positivity. And this just shows that we are generally doing enough tests to keep up with the pandemic and to ensure that we're catching majority of cases, hopefully. So 5 or below is the recommended level. And now if we look at it by state, you can see that a little less than half of the states are under that 5% test positivity rate, but 28 states have higher than recommended test positivity. And so this means it's an indicator that shows a combination of things, that testing is probably not widespread enough in those states, but also that there may be a surge in cases in those locations as well. So I talked a little bit about what we don't know about transmission. There are some living and working environments that we do know are particularly high risk for transmission. This is on the right-hand side here is from the New York Times. This is tracking the largest clusters of cases, and these are the top 10, I believe. And so what you see here is all of the top 10 in terms of numbers of cases in a cluster or outbreak are in prisons or other carceral facilities. So these types of facilities where there's high density, where people cannot physically distance effectively, where public health measures to catch cases and to isolate individuals who are sick and provide quarantine for those who've been exposed. Those are places where we're going to have higher levels of transmission. And so this is also true for places like meat processing facilities and other types of factories. We've also seen it on ships, both cruise ships and military vessels, like the Theodore Roosevelt. Those are where the large clusters of cases have occurred. But we also know that long-term care facilities and nursing homes are also very dangerous in terms of transmission. And they are doubly hit because the individuals in those facilities are also at higher risk of severe disease and death because of their age and possibly underlying health conditions. So those are the deadliest outbreaks that we've seen. And nursing homes and long-term care facilities have contributed to a large percentage of deaths in this country, unfortunately. Another thing I think that is important to mention is that not all communities are affected in the same ways from this pandemic. We are seeing that communities of color in particular are disproportionately affected. So you can see here, this shows that Black Americans are about 3 times more likely to die from infection with the SARS-CoV-2 virus than white Americans, and that is there are similar rates for Latinx individuals and indigenous populations. And even Asian Americans are slightly higher risk here as well. So what this indicates is that we need to really target our public health measures to make sure that people of color have access to high quality health care. They have access to testing. They have support systems so they can stay home and isolate and quarantine if they are sick or exposed. And these resources are not being applied equally among our society. So this is something to keep an eye on and to strive to improve. And then we can look ahead. There are modelers who are doing some forecasts, short-term forecasts that look ahead only a few weeks because of all the uncertainty. Most modelers won't look ahead more than a month or 2. But this is a good site from the CDC that kind of aggregates the different expert models that are being done to look at specifically deaths in this case. And this is important because the aggregation of the models has been shown to be more accurate than any single model. So this week's national ensemble forecast from CDC predicts that there will be about 3,000 to 7,100 new deaths during the week up to the week ending October 10th, so the next few weeks. And so it basically indicates that the trends we're seeing will continue, and these models will be updated as we have more evidence of what's going to happen as the weather cools and people begin to go indoors in the fall. So this is leading me into basically more about the public health response, and we're going to focus on contact tracing in particular. But my colleagues and I put out this report back in April, which looked at kind of what we call the roadmap for reopening. What are the tenets that we should try to follow in response to this pandemic? And I think although that is a long time ago in COVID time, I think the principles here still apply. So we are in phase 2, basically within a gradual reopening where we're lifting measures iteratively, business restrictions. We no longer have these blanket stay-at-home orders. We are hoping that by December or early next year, we will start to move into phase 3, which is the application of a safe and effective vaccine. That will be a very prolonged process in that only a small proportion of the needed vaccinations will be available at the time that it is approved for use. And then we do need to pay attention to phase 4, which is rebuilding readiness for the next pandemic once we get through this, because obviously we're learning a lot of lessons that we should apply and make sure that we're in a better situation when the next pandemic hits. But now I will focus on what we need to do for contact tracing. So really, to begin with, contact tracing means, just so we all have a baseline, if we have a positive case, that positive test is reported to the health department. The health department calls that person, asks first of all how they're doing, provides them connection to healthcare if needed or any other resources, and then also does an interview to try and understand who the close contacts were of that person during the time that they were infectious. So that means about 2 days before they develop symptoms, up to about 2 days into the course of symptoms. And the definition of close contact that the CDC and most states are using is contact within 6 feet for more than 15 minutes. And so those individuals will be contacted by a contact tracer or someone from the health department, and will be notified that they have been exposed and asked to quarantine at home for 14 days. Another important component of the contact tracing activities is to provide that those wraparound services, that extra level of support for remaining at home. In most cases, that means providing resources to get medications if needed, to provide food, to help with childcare or elder care if that's needed, somebody needs to quarantine, or even provide another place for them to quarantine that is not in their home if that is impossible or if it's not safe for them or their loved ones. In a very rare cases, I think providing funding for an individual who may have to give up income if they stay at home for 14 days, that is a best case scenario, although that isn't happening very often. So the reason we need to build this capacity nationally is to break chains of transmission. We have all taken these steps to stay home, to close businesses, to reduce transmission. I think we've gotten into a fairly good pattern where we know the very high risk environments and have discovered to what extent those can be open and operating without causing an epidemic. But once we bring case numbers down to a low enough level, that's where contact tracing kicks in. It's to really try to find as many cases as possible, get those contacts in quarantine, and break chains of transmission. And the more effective contact tracing goes on, the better control we have of epidemics. And so this can help us manage these epidemics at an ongoing low level. In some parts of the world, like New Zealand, this has been used along with other public health measures to virtually eliminate the virus from circulation within communities. I don't think we're probably going to get there in the US, but we can manage this at a lower, more sustainable level. And the idea is that we can prevent future waves or surges of cases if we get it under good enough control, because we will see the new cases that happen and we can catch an epidemic early before it goes unrecognized and then really expands into a much larger epidemic. And so this enables us to get back to work in a much safer way if we can do this. There's lots of challenges with that, and we can talk more about that as I go along. So the grand goal that we had back in April and March was to really scale this up nationally at the local level, but to a national level of about 100,000 new trained workers. The idea was to provide funding and guidance and buy-in from federal and state political leaders, and training and community collaboration would really enable this to happen. Just as a brief plug, my colleagues at Johns Hopkins put together a really great course on contact tracing. I think it's been taken by over 100,000 people on Coursera. This is free. If you just go to the Coursera website, you can search for the COVID-19 contact tracing course and take it for free and get a certificate. So that has been used as a baseline for training in a number of communities. And then contact tracers go on to have more in-depth training from that specific community. But all of these are components that are necessary for contact tracing national capacity. So I have, over the past several months, I've worked with NPR that has done, Selena Simmons Duffin has done a series of really great surveys, and we're actually in the process of fielding a fourth version of this survey now to try and understand what states have been doing around this. This was the second survey. This was back in June. At that time, there were about 37,000 contact tracers out of that 100,000 that was recommended had been hired across the country. And states indicated that there were about 68,000 reserved and planned back in June. And then this is the last survey that was done. It was at the end of July, early August. You can see that baseline number has gone up a little bit to 41,000 contact tracers across the country. But now there are only about 7,500 reserve staff planned or additional hires planned. So it looks like, based on the last survey results, we'll see with the next survey that this is kind of leveled off. There are a few states that have reached the recommended threshold early on, which was about 30 contact tracers per 100,000 population, but that's just a handful. And one other really important component of contact tracing is gathering of data. So there are two types of data that we think are important. There is the data about how the contact tracing is going, so including how much has the workforce been scaled up, how fast is contact tracing happening, how effective contact tracers are at getting a hold of contacts, and have they agreed to quarantine. Those are some of the process metrics that are important. There are also outcome metrics of this that are also really important. So trying to understand what percentage of cases are arising from people in quarantine. Ideally, you want this percentage to be high, because that means that individuals who are becoming cases, they're the next generation of cases, are out of circulation or quarantining at home. And so that's just one of the metrics that are important here. The other thing that is not directly related to contact tracing, but is something that can come out of case investigation and contact tracing, is trying to understand better where transmission is happening. As I said in the beginning, we still don't have a really granular view of where a majority of cases are occurring and why that transmission occurred. So these are all things that are important to be built into these programs. And this national map here shows the states that are both collecting these types of information and are reporting them publicly on a government public-facing website. And so you can see that it's a small proportion of states that are doing that so far. So we'll see, hopefully that is improving. So here's a really good example from the Louisiana Department of Health about some of the information that can be collected around transmission. This is not all of the cases that they're having, because it can be really difficult to identify where transmission has occurred, but at least it does give us a flavor of where the largest number of outbreaks are happening, where the largest number of cases are occurring. Sorry about that. So here, for example, you can see that there are a large number of outbreaks in bars, and the case number is high there, whereas this was back in July, so it may not hold true now, but in schools, there were a small number of outbreaks and cases. So this is really useful both for decision-making at the public health level and personal decision-making about where to spend your time, where are the higher risk environments. And here are just a couple of other good examples of some of the information that's being reported from Maryland, looking at the number of cases reached and interviewed weekly, and then from Delaware, similar information about cases with known exposure to another case. This is also a really good metric. We want the cases to be connected because that means we don't have large reservoirs of unrecognized spread happening in the communities. So this is all very useful information that can really improve our response. So I think these are the last couple slides here, but I just wanted to highlight some of the challenges with contact tracing. This is not a silver bullet, and I don't want to give that impression at all. This is a very difficult and resource intensive activity. I think it's critical for ultimately getting better control of the pandemic, but it is really hard. So some of the challenges are building up a significant workforce and maintaining that workforce. This is expensive. This is a tough management task. As I mentioned earlier, when case numbers, when incidence is very high, contact tracing can become overwhelmed very quickly just because the number of contact tracers just simply can't keep up with the number of cases. So even the best programs we're finding are overwhelmed at least at 10 cases per 100,000 population per day. It may be a lower level depending on the program. So we really need to bring case numbers down in order for contact tracing to be effective. Other challenges are lack of trust in public health authorities. For people to be willing to engage in this activity, there really needs to be a level of trust. And so this varies greatly by the community you're talking about. Recent problems with testing turnaround time make contact tracing much less effective. So if we're not getting a positive test result back for 3, 5, 7 days, that virtually makes contact tracing impossible, at least impossible to be successful, because by the time those contacts are notified, they may have been infected and may have gone on to infect someone else. So there are lots of problems in health departments right now with data infrastructure, just sharing information between laboratories about testing. I've heard from a number of people that health departments in some places are still using faxes. It's a real problem, and so that is creating difficulties for effective contact tracing programs. Cases can be reluctant to name contacts, and there may be many reasons for that. One primary reason is that for many people, their employers are not offering compensation for them staying at home or paid leave for them staying at home if they have been exposed in particular. So this is a real disincentive for both cases to name contacts because they know their contacts may be asked to quarantine, or for people picking up the phone and engaging with a contact tracer. And so if contacts are not willing to quarantine, if they're not taking that ultimate action to stop the chains of transmission, break those chains, then contact tracing is in and of itself is not very effective. But one piece of good news, I think, is that there is some emerging evidence and some modeling studies. Here's one modeling study that shows that even a lower level of contact tracing can help to get better control, can really reduce the case numbers and ultimately deaths. This study in particular looks at no tracing versus 20% of tracing, and they define that as individual contacts who've been notified and are staying at home in quarantine, versus 40% tracing effectiveness. And you can see that even at 20%, which is that solid line there in the middle, there is a big impact relative to no contact tracing. And so I think this is an important public health measure that we should be taking. It's not perfect. There are lots of challenges, as I just talked about, but it is a really critical component and can make a difference even with the imperfections. So I think with that, I will stop and field any questions that you have.
Thank you. Thank you so much, Dr. Watson. This is going to be reserved till the end of the webinar. So if you don't mind standing by for the many questions that we already have in the chat window, please continue to send in your questions. In the meantime, we are going to proceed to our next speaker, who will give us an update from the front lines in Georgia. This is Dr. Stephanie Hahn, who's the director of the Georgia Poison Center at Grady Health System in Atlanta, Georgia, and who has been actively involved in supporting our state health department in various COVID-19 response functions, including contact tracing. So I think her presentation will be a really nice follow-up to your excellent presentation. Thank you. Dr. Hahn?
Okay, thank you, Kazi. All right, so my objective is to describe the role of the Georgia Poison Center in the state's effort to trace contacts and disseminate important COVID-19 information during the current pandemic. So just a little intro into the Georgia Poison Center. We are the only certified poison center in the state of Georgia, in operation since the 1970s. We are one of 55 poison centers in the country, and we cover the entire state of Georgia, which has a population of about 10.8 million residents. We are located in Atlanta, Georgia. We're also considered a grant-funded department of Grady Health System. We're staffed by nurses, pharmacists, physicians, health educators, public health med secretaries, IT staff. We are managed by a whole bunch of directors, medical director, executive director, director myself, all board certified in toxicology, along with 7 medical toxicologists. And we have a very robust training program at our center. We currently run 3 fellowship programs at our center, one for physicians, one for pharmacists, and one for international postdoc toxicology fellows, as well as hosting plenty of nursing, pharmacy, and medical students throughout the year. Our mission as a poison control center is to medically assess, triage, and manage human and animal poisonings. And we do this 24/7. However, we have also been collaborating with Georgia's Department of Public Health for more than 2 decades in the triage and tracking of public health events. Initially, we started helping the state public health department with animal bite assessment and management by providing the consultation for rabies, prophylactic treatment after an animal encounter. We do this through the Poison Center hotline. Eventually, we created a separate public health hotline staffed by our center, which provides a 24/7 gateway to the general public and healthcare professionals of Georgia on other public health related events or concerns or questions, such as foodborne illness reporting, restaurant food complaints. Our public health hotline now serves as a mechanism for healthcare professionals to report notifiable diseases to state epidemiologists. And we also manage other public health related calls such as mold in the home, mosquito complaints, blood or bodily fluid exposures. Our public health hotline even has a role in bioterrorism and mass casualty incidences if they occur in Georgia. Okay, so again, just in summary, here's a list of our services provided by my staff at the Georgia Poison Center involving 3 separate hotlines. Our center has had an extensive history helping our state's public health department with a variety of recent public health threats, such as H1N1, participating in active monitoring of international travelers during Ebola, disseminating info on Zika, and now with COVID. Poisoning has been recognized as a public health issue for a long time. And that was really one of our pitches to Department of Public Health years ago when we started establishing a relationship with them. They quickly realized that with our current infrastructure and our staffing, that we would be an effective and an efficient entity to help them track and triage other public health events in real time. We already have a clinical staff in place. All public health related management and manuals and talking points are given to us by actual public health officials, and they train our staff on these talking points. So I feel like over the years, we've really proven to be a cost-effective partner for our Department of Health over the years. And we are certainly seen as an extension of public health in Georgia. Oh, okay. Forgot all those were in there. All right, there we go. So just to remind everyone a bit of a timeline on COVID. So January 9th, the HWO announced this mysterious pneumonia coming from China. January 21st was the first documented US coronavirus case confirmed in Washington state. Sometime in mid-March, the pandemic was eventually declared, and United States started issuing several international travel restrictions. The COVID-19 pandemic was first detected in Georgia on March 2nd of this year. It involved a father and son in Atlanta, Georgia. The father had just recently returned from Italy. The state's first death came 10 days later on March 12th. And as of September 20th, we have now over 300,000 confirmed cases. So that's approximately about 3% of Georgia's population. As of September 20th, we have over 2,700 hospitalizations for COVID so far in the state, and we are soon approaching 7,000 deaths. The staffers who answer calls for the public health hotline started capturing COVID-19 calls in January. And it was mainly, what is this thing? And what are the symptoms? Should I travel? How do I get tested? And not knowing where we were going to go with this, they managed, all of these calls were managed by our team, by our staff, our public health, medical secretaries. And we have 5 of those, by the way, that work a variety of shifts and hours Monday through Sunday. Any overflow calls were then managed by our poison specialists, and all of our poison specialists are cross-trained in all of our public health talking points as well. So in February and definitely in March, after we first saw the cases in Georgia starting to appear, call volume got so high to a point where I was offering overtime to poison specialists to try to help cover the public health hotlines, and not exactly sustainable. Fortunately, in March, as schools and businesses were shutting down, we knew this wasn't going away anytime soon. We did receive separate funding through the Department of Public Health for our COVID-19 efforts in March. We hired medical secretaries from a temporary staffing agency, about 15 FTEs, with about 30% of them being bilingual. And this was over a course of 2 months. We hired all of those staffers. So we staff the public health hotline then and now, Monday through Sunday, 7 a.m. to 10:30 p.m. with these temporary COVID staffers. Call volume is low enough after 10 p.m. that the poison specialist then can pick up the call volume until 7 a.m. the next day. Eventually, we also created a separate COVID-19 prompt when dialing into the state's public health hotline. Like press 3 for COVID, press 1 for this, press 2 for that, press 3 for COVID. So these pre-recorded messages were developed which really assisted with the delivering of these messages and this information. And it really minimized callers thus having to wait to speak to a live agent. Many people, and we track this in some of our statistics, I'll show you in the next couple of slides, many people would just call in, spend maybe minutes on the line, just listening through all of the messages that we had pre-recorded and available. And maybe that was all that they needed to do, and they didn't necessarily need to speak to a live agent. So how we, the Georgia Poison Center, disseminated COVID-19 information and provided services for the state of Georgia. So obviously, number one, I've talked about the hotline, and this was our primary way to get information out there that we were involved with. So we advertised our 1-866 Pub Health hotline on our Poison Center website. Georgia Department of Health advertised it on their website. The governor advertised our services. Media obviously was involved at times. And the purpose of the COVID services through our hotline was to provide general COVID information to both healthcare professionals and the general population of Georgia. So here were some of the examples of the calls that our staff often and still take via the hotline. So healthcare professionals. So they call in often with isolation procedures, clarifications, testing locations, how to test, what test is the most accurate and what I should be using. Again, we serve as a reporting mechanism for positive or confirmed notifiable diseases for the state, including COVID-19 cases. So of course, many healthcare professionals call us to report COVID positive patients. CDC guidance interpretation is a popular healthcare professional question. And very important, we provide a direct pathway for a physician consultation with a medical epidemiologist. The state has medical epis on call daily for consultation on public health related events, not just COVID, but for a variety of other things. The general public, what are some things that the general public are calling us about? Oh, so sorry, I lost connectivity there for a second. Okay, general public. So what are some things that they're calling us about? Well, obviously testing locations, testing. Probably the second most common question we get from the general public is, where are my results? I think everybody is aware that many locations in the country, including Georgia, including regions in Georgia, sometimes the testing turnaround time is not what you're told. Whenever you get your tests, you're maybe told 2 to 3 days. Sometimes it's been up to 7 to 10 days, depending on volume. So that's a very common question we get, and we try to help provide some information to our general public as to where to go next. Travel restrictions, mask hygiene questions. My staff, they are not the contact tracing investigators, but we still provide contact tracing assistance. And I'll show you what we do in the next slide. Businesses, we're very popular with businesses. The governor's executive orders and ordinances, local ordinances, are pretty hard to interpret. So we try to provide some interpretation to anyone that calls regarding businesses or how they should run their business, when to return to work, when it's safe for their employees to return to work after a COVID positive situation. And then, at times businesses or people will complain about businesses not being compliant, and we will provide them with information on how to file complaints. Another way that the Georgia Poison Center helps disseminate information was partnering with the Public Health Department and an app called Punch Alert, which is a push notification company to provide Georgians with the latest alerts, information, and recommendations from local government officials. We currently have over 7,000 subscribers to this system. So here are just a few screenshots of my own phone of what I see when I get a notification. My executive director, Gaylord Lopez, and our health director, Brittany Overall, work directly with a team of epidemiologists over at the Department of Public Health to coordinate and send out messages via Punch Alert. So we at the Poison Center operate the dissemination, and the Department of Public Health provides us mostly with the content, from testing locations, update, isolation procedures, to sharing the latest medical literature published involving COVID-19. So this has been a really exciting and innovative collaboration with DPH. It is free. It targets Georgia residents, but really anybody can sign up. And I kind of skimmed over this. Let me just quickly go back just to show, if you go to our website, georgiapoisoncenter.org, you can get the instructions, you can download the app from there, from your favorite app store. And then if you just text one of the following phrases to 77297, you can subscribe to get messages that are, directed mainly toward the general public regarding COVID, and they're available in either English or Spanish. Or if you're a healthcare professional, you can also subscribe to get things like the current medical literature out there or being published regarding COVID. Okay, so the public health staffers and the temps of the Georgia Poison Center assist with contact tracing with the state. So again, we're not the investigators, but after the investigation is complete and people have been identified to quarantine for 14 days, they are, as you know, instructed to call in their health status daily to the health department of Georgia. Preferably, they either respond to a text, yes, I am asymptomatic, or no, I'm starting to have symptoms, or they log in with their own computer to a personalized Google MTX link. And they can go ahead and submit themselves their daily reports. So Google MTX is the platform that is assisting public health officials in Georgia with their massive contact tracing effort. It's a personalized database that contains names, birth dates, location, health status of those that are asked to be in quarantine. So even if a person who has been in contact with a COVID positive patient who is not contacted by an investigator, they are encouraged to even go online to create their own Google MTX profile so that they can be traced. And of course, where we fit in again is if a caller doesn't have the ability to text, or if the caller doesn't have their own computer or have internet to be able to go onto the computer and enter in their own daily updates, they can call, hopefully they have a phone at least, they can call into our center daily 24/7 and report their status temps. And their temperatures and their symptoms to us. And then we can go ahead and enter it into Google MTX for them. Roughly about 30 to 40% of our calls daily into the hotline assist with contact tracing efforts. 30% of our calls daily require us to enter Google MTX to help with the contact tracing in Georgia. Okay, so training, real quick on training. It takes about 1 to 3 weeks of training. The Poison Center and the Public Health Department developed a COVID-19 manual, which contains scripts and contact numbers and guidance on documentations. It's about 70 pages as of September 20th. It was 3 when we started. The Poison Center also developed years ago an intranet to provide a variety of services for both poison and COVID specialists. And we went ahead and uploaded these manuals and quick sheet references in case people want those resources electronically. The Poison Center directors also hold weekly meetings with the Department of Public Health to chat about operation, funding changes in protocol, and then those updates get disseminated down to the specialists via spot lectures or training events. We may even hold day-to-day meetings with the COVID-19 staff just to answer their questions and concerns about any new or current talking points. So here's our call volume. Here's a graph of our call volume over the last 9 months. All public health calls must be documented in our Poison Center's electronic medical record. The orange represents all public health related calls and charts that were created, like mold calls, restaurant complaints, COVID calls. The green line represents just the COVID charts that were created. In March, again, is when we created the COVID queue for our hotline. So again, press 3 for COVID related questions. So the white line represents COVID calls. And as you see, that white line is always just a little higher in call volume compared to our chart lines. Again, people just may call in and listen to pre-recorded messages without needing to speak with one of our members. So the call trend here over the last 9 months is kind of similar to our spikes in COVID cases in Georgia and maybe even nationally. Like we had a spike of call volume before the lockdown. That makes sense. A lot of questions about schools and businesses. It was kind of quiet during the lockdown. That kind of also makes sense. Everyone was home, no one was doing much. And then it peaked again during the summer months when we had a spike in COVID confirmed cases in Georgia. So my last two slides, challenges, obviously variable call volume, unexpected call volume, making sure that we're appropriately staffed for the call volume that may change or whenever it's quiet. The changing guidelines and often hard to interpret executive orders are always a challenge for us, trying to stay on top of the most current information. Employee attrition, anyone who's worked with temps in a temporary agency, everyone knows how hard it is to keep temps. Temps leave, often give little notice. The time it takes to train these folks, again, is about 1 to 3 weeks. And my goal was always to try to keep 13 to 15 FTE staff at all times. So I've held so far 8 total training sessions over the last 6 months. And then we've worked with a lot of laboratories over the United States that don't really know our specific policies and procedures for reporting. So that's always been a challenge, working with a lot of out-of-state entities and companies and reporting mechanisms to making sure that we have the most correct information to then start contact tracing investigation. And then operating while socially distant. So here's a pic of our call center again on the bottom, but off to the upper left-hand side is our HQ2. We just finished finishing touches on our headquarters #2 to try to help with the socially distancing requirements that we even have in our own center. All of our poison specialists are teleworking 100% of their shifts, but the temps are not. So the temps are taking up all of the poison center, call center desk space. And so fortunately, with our friends over at Clayton County Health Department, we've built an additional 8 desk space area there. And this is now the home office for 7 of our COVID temp staff. Again, just trying to spread out and be distant. Finally, and thank you again for listening to this presentation. So look, I think we've all been told that COVID's not going anywhere. Looking into the future, the Georgia Poison Center will continue to staff the COVID-19 queue of the 1866 public health hotline well into 2021. We will continue to collaborate with Georgia Department of Public Health on updating COVID talking points and highlighting the services provided by the state. We will continue to assist with testing efforts, laboratory data collection, interpretation of updated health guidelines and executive orders of Georgia. And we are definitely preparing our manuals and talking points to include COVID-19 vaccination. And we'll definitely assist however way we can with widespread vaccination programs that will likely and hopefully be available throughout the state of Georgia, maybe in sometime 2021 or 2022. Hopefully, fingers crossed. So this concludes my presentation for the afternoon. Please reach out to me if you have any questions regarding our COVID-19 efforts in Georgia. And I thank you.
Thank you, Dr. Hahn, for a great presentation that complements really well the first presentation. We have many questions in the queue, and we will have to stick around till 4:15, I believe. So we appreciate your patience and sticking around if you can to go through as many questions as possible. I will go ahead and turn it over to Dr. Wax, and then I think we'll both of us try to tackle all of the questions in the chat. Dr. Wax?
Great. Well, thank you very much to both Dr. Watson and Dr. Hahn for 2 excellent presentations. I just have a couple questions at the outset for Dr. Watson. You being an expert in this field, what has surprised you the most about what's unfolded with this pandemic from an epidemiological standpoint?
That's a really good question. I think it has followed a fairly predictable pattern in terms of epidemiology. I think what has surprised me more is kind of our human behavior, I think. So first, one surprise to me, and something I don't think we fully anticipated in our preparedness work and planning, was the willingness of our populations to really take these stay-at-home measures and social distancing measures. so seriously. And I know some of that is waning now, but I do think that was an important lesson that we've learned from this. It's not the ideal way to manage a pandemic, but you have nothing else. It was surprising to me how many people were willing to take those measures so fully. I think one takeaway that I have is that leadership makes an enormous difference in response to a pandemic, and that is something that I don't think we fully appreciated prior to this as well. That encouraging use of a data-driven response and building public trust is really, really key for a successful response. And we've seen examples of where that has happened, and there's been better control of the pandemic versus when it hasn't. There has been a lot more transmission and unfortunately a lot more deaths. So I think those are the two surprises and big takeaways for me.
Great, thank you. Could you just comment briefly about the cost of implementing the contact tracing programs? Who's funding the contact tracers at the present time?
Yeah, so I think there are a combination of funding sources. I know that state and local health departments and governments are putting a lot of their own resources and funding into this. There has been some federal support that came in some of the earlier relief packages in the year that was intended for a broader public health response, but could be used for contact tracing. I think it depends on the jurisdiction, how much of that funding went to contact tracing versus other public health response activities.
Okay, great, thank you. And in terms of contact tracing in the US versus overseas, particularly in Europe, how are we faring, and what are the lessons that you might have gleaned from the contact tracing efforts overseas?
Yeah, I think there are a few really great examples where contact tracing was used effectively. New Zealand is one good example. Iceland, a number of places in Europe and in Asia have done a very good job at contact tracing. It's difficult to compare to the US because in many of these places there were very rigorous steps taken early on to prevent introduction or to limit introduction and community spread, more widespread testing early in many cases. And so few countries have the level of transmission that the US does and are still scaling up their contact tracing workforces to deal with that. So I think that we are seeing some really good successes in the US in places like New York City and Massachusetts, North Dakota. There are a number of other examples as well, but it's not uniform across the country, and we have very different conditions from many other parts of the world.
Okay, great, thank you. Regarding the milestone of the 200,000 deaths that we recently passed, any sense of how many of these people might have died with the SARS-CoV-2 virus as opposed to as a result of the infection, and also any comments about perhaps this is an underreporting of the true fatalities as well.
Yeah, I think the vast majority of those reported deaths are deaths due to COVID. There may be some cases where individuals had COVID and actually died from another indication, but I do think that is a fairly low percentage. What we do see are that there are a large number of deaths that are basically not attributed to COVID, but are excess above the deaths that we would see in a normal year. And so we also think that a vast majority of those are also because of infections with COVID-19. Some of those may be people who were unable to get care because they either couldn't access care for other diseases or heart attacks, things like that. or they did not want to access care because they were nervous about COVID. So there's a combination there, but we think that there is actually a vast undercounting of COVID deaths.
Okay, great. Thank you. Are you familiar with much data about the transmission in terms of people flying commercially and the transmission of COVID?
That's a good question. There was just a paper that came out on this that looked at the overall estimated number, but I haven't reviewed it yet. I do think that there are conditions. Obviously, it's a high risk activity because you're sitting on a plane in close proximity with many people for an extended period of time. The positive there is that there is a high air exchange rate, which can reduce the risk of infection. And so I don't think it's a main driver of infection, but I'll try to find that paper and send it to you so you can circulate it.
Okay, great, thank you. Okay, well, let me turn this over to Dr. Kazi for some additional questions.
Thank you, Dr. Wax. Now, I have a couple of questions regarding some of the data you presented. One of them was related to Puerto Rico. In that table where you looked at the positivity rate, it seemed to be 100%. Is this correct? The test positivity rate for Puerto Rico is 100%.
Yeah, I'm not familiar with the exact data that underlies that, but so it could be a fluke of reporting, but it could also be that they are testing only the most severely ill individuals, and so the likelihood that they have COVID is much, much higher. In this case, 100%. I'm not sure which case that is here. Sometimes in the data that we report, there is a day where the reporting is off, but I'm not sure which case that is for Puerto Rico.
Thank you. And then regarding the turnaround time for the tests, many public health experts have really been very vocal about the importance of rapid turnaround times. In your opinion, what is the threshold where a turnaround time is too long for contact tracing to make a difference?
Yeah, I think ideally what we want is that cases are interviewed within 24 hours of a positive test, that contacts are not only elicited but also contacted within another 24 hours, so a total of 48 hours within the receipt of a positive test. And much beyond that makes it really difficult to break chains of transmission. And so when you add on top of that more than 24 hours or 48 hours for a test result, then it really becomes so much less effective. So I think the goal is for 24-hour turnaround time for test results. 48 hours, I think, is still acceptable. Anything beyond 72 hours, I think, makes contact tracing much less effective.
Thank you. And then regarding you showed some compelling data regarding the racial and ethnic differences in mortality. What do you propose in terms of actions that could mitigate this risk in some of these vulnerable groups?
Yeah, so there are a number of things that I think can reduce risk. So first is workplaces providing paid leave to individuals, and governments pushing for workplaces or providing resources for workplaces to do this, because a number of people who are working in these frontline jobs often tend to be people of color, and so they are at much higher risk just because of their work environment. So that's one of the first things. Then I think being strategic about testing resources and making sure that those workplaces offer testing, that vulnerable communities have really ready access to testing without the need for a physician providing a referral, for example. Just increasing access for testing so people can understand if they've been infected. And then also providing better access to healthcare early on, so that people aren't waiting until they're really sick to access care. This is a tougher thing to do. It's hard to fix in an emergency, but But I think the combination of these measures are all really important to reducing the impact on vulnerable communities.
Thank you. I'm going to ask maybe a little bit difficult question. One of our members has asked really your opinion or your optimism regarding the feasibility of contact tracing. And in his opinion, it's really difficult to accomplish and maybe futile. Would you like maybe to comment on that?
Sure, and I can understand that pessimism because it is very difficult. But like I said, I don't think that it only makes a difference if it's being done perfectly. I think it does make a difference even at fairly low levels. I do think an important takeaway, though, is that we can't rely only on contact tracing. And I think in a number of cases, political leaders have kind of put the onus on contact tracing or the blame on contact tracing for not controlling epidemics when that's not reality. So what we really need to do is take these other public health measures, individual measures to reduce transmission, population level measures to make sure people aren't putting themselves in risky situations where transmission can occur, to bring those case numbers down to a manageable level. Once that happens, we've seen many examples across the world that contact tracing there can make a difference in managing the pandemic in an ongoing way. So I don't think it's futile. I think the situation in the US right now is very frustrating. But we are seeing glimmers of hope in some parts of the US. It's just basically what level of resources and commitment do we want to put towards this activity nationally? That is the open question.
Now, we have colleagues and friends in different parts of the world, like Southeast Asia, that they've used some technology tools for contact tracing. Can you comment on those? Are those more effective, and why are we not doing those in the US? Or are we?
Yeah, so this is really a new thing for public health. Before COVID-19, for the most part, this wasn't a tool of public health, was to do digital contact tracing. There were digital tools to help contact tracers, but not this, what people are probably most familiar with, which is exposure notification, which is the Google-Apple partnership. And so it's in the process of being taken up. It's in the process of being researched to try and understand its effectiveness. We don't really know how effective it is yet. In the US, there hasn't been much uptake of this because the Google-Apple approach to digital contact tracing or exposure notification doesn't provide information to health departments. It allows someone who has the app to notify their own contacts, and those contacts can then choose to quarantine or not. So it doesn't directly aid contact tracing. And so, and the onus has been put on health departments to develop their own apps up to this point, which I think generally they haven't had the resources for. So it hasn't been widely adopted in the US. Now, Google and Apple have introduced a new approach where an app development is not necessary for a state to adopt this. And so I think we may see additional states. In fact, a handful more states have now announced that they will be employing one of these exposure notification tools. So we'll have to continue to gather evidence. The way I see it is that it is possible that it could add additional benefit onto what contact tracers are doing already. I don't think it takes the place of manual contact tracing.
Thank you. I'm going to actually ask two quick questions to Dr. Hahn related to the contact tracing. Dr. Hahn, we've had two participants ask, one regarding the homeless population in Georgia and how contact tracing has been done for that population. Second question is regarding HIPAA compliance and the Georgia MTX Google form.
Oh, those are all really great questions, and I will do my best to try to answer them. what Georgia has done for the homeless population is really been trying to reach out as much as possible to the potential shelters that they may be going to, and touching base as much as they possibly can with the shelters. Shelters generally know who, for the most part, who may be coming in and out of their shelter at various times. I know that there have been efforts within the homeless community of Georgia, and definitely here in Atlanta, disseminating much needed items such as masks, disposable masks, little bottles of hand sanitizer, and information. You know, some of the population do have access to a cell phone, although they may have very limited access, maybe only emergency use to a cell phone. So therefore, they may not have texting or internet available. But I mean, many are. I know there are EPIs and local epidemiology and contact and trace efforts to try to just also work with homeless shelters, trying to also just provide testing to those homeless shelters, or having testing days, or advertising testing for any of those that may want to get tested. That's the best that I'm aware of. I'm trying to represent the state as much as I can with that answer. In regards to HIPAA compliance, I'm I'm not sure. I unfortunately don't know the full ins and out of Google MTX when it comes to HIPAA compliance. I have to assume that it's password protected, and it is all the information stored, I believe, on local servers that the state has full control over. Other states, I believe, such as Massachusetts, has also invested in Google MTX platform software. And it's Google run, so the encryption and the password protection of it is very similar to other Google services that are heavily password protected. Things need to be updated. Passwords need to be updated every 30 days or so. Again, we all get training from the state on exactly how to use it and how to enter the database. It is also monitored by people at the state, I believe, to make sure that the database is being used appropriately versus inappropriately.
Thank you, Dr. Hahn. I'm turning over to Dr. Wax for the sake of time, if he wants to ask a few more questions and conclude. Dr. Wax, thank you.
Great, thank you. Well, I just really have a final question for Dr. Watson. You know, the majority of the folks on this webinar are healthcare professionals. You know, there are others as well. You know, folks that are often traveling, getting on planes, going to restaurants, going to the gym. You know, if you took your kind of average community in this country right now, not the highest end or the lowest end in terms of viral transmission, you have any advice about those three things? You know, getting on planes, going inside to restaurants, going to the gym.
Yeah, that's an important question, and those are some of the most important places for me to go to. So right now, incidence is so variable across the country, even among within states, that it's hard to make a blanket statement. I think if you want to look at the incident in your local area or your state, that looking for an incident rate per day of 5 cases per day per 100,000 population or lower is what we're aiming for. Lower than that is even better. I think 3 or even less than 1 is the goal that's just been put out from the White House. I personally, I am in probably one of those places where you would say kind of is in the middle, which is Maryland. And I am not comfortable actually doing any of those activities currently, because we've seen a lot of transmission, particularly in restaurants, eating indoors. And I think all of those environments are tough. If you have to travel on a plane, that's obviously a risk you're going to have to take. But I have advised my my family to try and quarantine after that, or at least get tested 3 to 5 days after travel. So I think we're still at a place where there is a significant amount of community transmission, and so those things are not very safe at the moment.
Well, thank you very much, particularly for your frank comments there. Next slide. Again, I'd like to thank both of our speakers for two really outstanding presentations. This has been recorded and will be put up on our website within a couple days or so, and everyone will get notifications and with the link once it's uploaded. Also, we'll try to sort through some of the questions that did not get answered today and see if we can provide some responses to those as well. Again, if you have any questions about the series in general, we welcome the feedback, and you can contact us at webinars@acmt.net. Next slide. We'll be continuing this weekly webinar series. Next week, we have Dr. Ann Wiley, who's a research scientist at Yale University, and she's going to be talking about the latest in saliva testing, which is a new approach now to testing. We'll also have an update from the front lines in Lebanon, in the Middle East, and have two speakers talk about their experiences in Lebanon. Next slide. Our full program since March has been preserved, and this prospectus provides a guide to all the webinars we've had over the last 25 weeks. They're all available for listen to on our website, and including the slide decks for each presentation and various FAQs. At this point, I'd like to thank everyone again, thank the excellent speakers and all of you for attending, and have a good day.